Szeretettel köszöntök mindenkit a finom ebéd után. Próbáljuk.
Good afternoon, everyone. I would like to suggest that everyone take their seats. We should move on with our program because, as you know, we also have evening programs. So while people are putting up my presentation, I would like to say thank you to the organizers. I think you are really a world champion in more than one sense of the way, more than one sense of the expression. So, I have changed the title to some degree, and I decided to speak about the possibilities and the limits of orthopedic interventions in CMT, DMD, and SMA. Now, foot deformities is an area that I would like to not touch upon because Mr. Pfeffer, the presenter right after me, will speak about that topic. Now, in my practice, I see a lot more SMS cases than DMD and CMT cases. So I will be quoting literature often. Let's start with scoliosis. I would like to talk about the conservative treatment without an operation of scoliosis in children. That's before the spine of this individual is operated by Dr. Tunyogi. So we have about 30% of cases where we have a left convex thoracal twisting, basically a curve in the spine. Typically, we don't know why this happens. Now, in orthopedic textbooks, we usually say that if you find this type of scoliosis, this curve,
300 beteg adatait földolgozva szintén azt
we should look out for a possible neuromuscular cause in the background. Now, in history, children with scoliosis were usually only diagnosed at about 13 years of age. Duchenne is a different situation. An independent Texan research group showed that this happens in 38% of this population of children. And there was a minor study as well, which made a statement, or at least an observation about DMD treated with a corset that is very tightly fitted to their bodies. You know, there are major difficulties with this treatment, but they found that in the initial stage, these curves, even though are large curves, they are also very flexible, and it is only later in their age that they become rigid. And during the flexible time, the corset treatment for children can be efficient if you define efficiency as slowing down the worsening of the condition of the patients. So that's another indication that a corset could be a good idea early on, as early as possible. Now, we have also another study. I don't quite understand why my slide is kind of confused in terms of its graphics, but whatever. So we checked 24 patients with spinal deformity, SMA 1, 2, and 3. And we found that it was about age 9 when they visited us for the first time. And SMA 1, 2, and 3 frequency rates are given on the left pie chart. And then we tried to sketch up a relationship between the severity, which is the Cobb degree, COBB, the deviation of the spine from the straight line. And we have a very interesting result. It shows that the older children are, the less severe the curve is. But looking at this surprising data, we see that those children, older children, were only SMA type 3. So we split the chart into two, and with SMA 1 and 2, we have a straight line. The older they are, the worse the situation is. We were considering scoliosis of over 20 degrees, whereas in the right chart, we did not see any correlation between the degree of the scoliosis, and we did not find a correlation with the degree of scoliosis and the time, that is age. This is also a chart of the expected progression, the expected deterioration in the condition of the children with SMA 1, 2, and or 3. So these children, these patients were not necessarily treated from an early age on. We will continue recording this data and, so to say, purify or filter the data set, which also shows that progression is kind of weaker or more limited in type 3. Now, every presentation has to include one slide that completely confuses the audience. We like this chart because it shows how the arrows show what is related to what, and then people are trying to describe what's what. We don't have to understand this in detail. We don't have the time to do that. But the main message for me, at least, is that the motor function of children, which is directly related to their quality of life, depends heavily on their neck stability, on their upper body stability, and on the rate of their scoliosis, the extent of their scoliosis. So the more severe their scoliosis is, the worse their body functions are. And what we see in SMA as well is that in an earlier age, when the scoliosis is more limited, then a treatment with a corset, a Chenot corset, will help. When kids are not yet able to sit, but we still need to have them sit up, or if they can sit with very poor upper body tone, but maybe just supporting themselves with their hands or otherwise, then we should start applying the Chenot corset. And then I found some literature which said, let's use bracing proactively, because this is the line without proactive bracing, when they only started when it was already as bad as 20 degrees. The more, the top, so the chart shows that Cobb degrees that we can expect over time are much more favorable if we start using a corset proactively before even they reach 20% in 20 degrees in scoliosis. Now, let me talk about something that I also cover when I teach at the university. Let me show you how your hip joint works. There's a socket and there's a ball. And the socket doesn't cover more than half up to the equator, down to the equator. I'm talking about children who are not neuromuscularly compromised. We're just talking with people children who have dislocated hip joints, and then we have to treat them. Now, neuromuscular hip joint issue is completely different because their joint is completely healthy to begin with, but there is a muscle issue, and what happens is that the ball of the joint basically migrates, dislocates out of the socket because the tendons, ligaments, and the muscle are not strong enough to keep them in their place. Now, what I show you is a complex hip joint correction intervention, and this socket is basically cut, chiseled out of the pelvis. It is turned rotated and then put back with metal fixtures, hardware, and it's supposed to help children. But if you have spasms, if you have other muscle problems, then this might work. However, in the case of SMA, when the muscles are not strong enough, then even though you have executed an operation on them, the socket might still just loosen up and completely fall out of the joint. Can simply just fail to function. I apologize for the and we performed another piece of study on DMD where we have more of a consensus among professionals, which says that there is a correlation between the degree of pelvic issues with age. There is a straight correlation between the two. The older they are, the more displaced, the more skewed the hip is, the pelvis. And this basically means that whichever socket is higher up will be compromised and get dislocated over time. Now, checking our own SMA patients, we were able to filter the population, and so we only studied SMA 1, type 1 patients, seeing what factors play a role in displaced pelvic joints. And of course, we considered what treatment they were receiving, and we did not see a correlation. We also did not see a correlation between their condition and their gender and their sex. So what we thought that maybe age at the time of the first treatment is what matters a lot. In each of the cases we studied, they received drug treatment, nuciners, and then our software was able to show some correlation, weak correlation, but there's too much of a scatter.
Összefüggésnek, ami viszont erősnek látszik.
What we did see was that the higher the CHOP intent score was, the higher the chance of a dislocated pelvic joint was. So just very recently, we had a conference of European orthopedic professionals working with children, and there was only one presentation that was dedicated to SMA. None of them were focused on CMT, and two were focused on Duchenne. Of course, we did run out of time at that conference as well, but there is no consensus on whether we should fix the dislocated pelvic joints of SMA type 1 children. And I would say I'm conservative.
Nem tenném vissza, és ahogy hallottuk Kiara előadásával, ez meglehetősen egybe.
And as we have heard from Kiara's presentation, it's highly likely that they will not be able to walk independently outside therapy. And in contrast, it's interesting. I have indicated SMA2 in brackets, who will receive treatment already from childhood, and this will not have the same clinical picture as before, whereas SMA3s, where we most of the time detect displaced hips in their teens. This is the X-ray picture of a 10-year-old girl, and to my shock, I managed to move her left hip joint. And then I consulted spinal surgeons, and we agreed this level of scoliosis does not warrant an operation, so let's do everything we can to stabilize the pelvis.
And that was especially important because later I learned that this young girl was trying to keep this joint from actually getting dislocated. These two photos were taken at the same time, sitting and standing, which means she did not have the degree of scoliosis that we assumed. She only had a curved spine because she was trying to protect her own pelvic joint.
És egy másik csontból vett.
And so instead of fixing her spine, we decided to stabilize her pelvic joint. And this was the result. The photo on the right is her standing X-ray. We still have some scoliosis, but it looks a lot better than before. However, can we start the video? Can you help me with that? Okay, so the left one was before the operation. She was kind of throwing her leg to stabilize her hip. And then after operation, her walking is actually better, but her upper body sways more. So overall, her stability has not improved. So the musculus gluteus medius, the middle muscle dominating the butt cheeks, I had to move it away during the operation. And after it healed, its function became somewhat weaker than before. This is the story that we have. This is what we could achieve. I don't think we are operating too many children with this condition. I think I have operated on 2 or 3. Now, I also found another study that's kind of oldish from 1999, which shows that the curve that shows the ability to walk tells us that children who were operated on their soft tissues at around the age of 7, which could be the Achilles tendon or any other soft tissues, their results are actually better. I have myself never operated on kids in this age. This is when children usually come to us with contractures at the Achilles tendon. And maybe because of this, the failure of the last 2 operations, make me say we shouldn't operate because we will not be able to help the children, and we will not help the family either, while we expose them to quite a hassle with the operation and the healing process. Now, I also checked a publication by Professor Achadi that he himself mentioned, and because he explained most of this, I will skip that part and close my presentation by saying that I think Professor Mona said that we need to encourage young people to join this movement, this team. And I was very much motivated at the conference I referred to earlier. For us to be here, you have to both do science and take care of kids. So obviously, people who join this team will not be driving the red car. But hey, thank you for the attention.
Hello Glenn, be fogom mutatni.
Let me now introduce